Hi everyone, this is Dr. Wiesenden. I'm going to be giving a quick online talk about medical, legal, and ethics in anesthesia. Full disclosure, I am not even close to an expert in this content area, so what I have done is gone through and tried to highlight some of the more salient points that might be found on exams. So my references I used were Big Miller, and then I also used the anesthesiology review for the basic exam by Jeff Berger. So you have access to both those resources if you want more information, but again, I'm just trying to highlight what came across as some of the more important points and things that can be found on the basic exam. So the objectives, things that you should achieve by the end of this quick talk. The first is to distinguish the difference between beneficence and non-maleficence and apply them to the anesthesia setting. The second is to describe various aspects of professional liability, including medical malpractice and disclosure, along with reforms that have been designed to reduce costs when it comes to malpractice. The third is identifying laws and regulations that affect medical malpractice. A lot of these you've already seen and are aware of. Some I'll introduce or reintroduce. The next one is explain the various legal and ethical aspects of informed consent, including the four items here: decision-making capacity, voluntariness, disclosure, and recommendation, and I'll talk about each of those. The next point, explain the various legal and ethical aspects of end-of-life care, including the three types of advance directives and the rights of a patient to refuse care. And then the last is describe unique legal and ethical situations that you might find in anesthesia, things that you've often come across: pediatric patients, pregnant patients, DNR orders, Jehovah's Witness, physician-assisted suicide, and physician participation in execution. So, getting to our first point, the first two are the ones I'm going to focus on, and then the last three are some other terms that the authors in your textbooks found relevant and things that you might find in exams. So beneficence is simply action that is done to benefit others. In anesthesia, you might think of this as doing a block to prevent pain afterwards, or giving IV pain medication or anti-nausea medication. And then non-maleficence is to do no harm, and this is refraining from providing ineffective treatment or acting with malice towards the patient. Acting with malice would be an extreme example, but in our situation or our setting, one example of non-maleficence might be if you see a patient getting an adverse reaction to a transfusion or to a medication, and then stopping that medication, obviously not continuing to give that medication, would be an example of non-maleficence. When you look at informed consent, it often does balance beneficence and non-maleficence, and tries essentially risks and benefits. However, they often do make the point that even if you have informed consent, if something goes wrong, it does not recuse you or does not prevent legal liability in those situations necessarily. Medical negligence, in the parentheses here, you've got the definition of negligence. And medical negligence is a physician's failure or breach to meet the standard of care or duty that directly leads to a patient injury or harm. And then the last one is autonomy, which is simply the patient is independent and can make fully informed decisions regarding their health care, have the right to accept or refuse diagnostic or therapeutic interventions. However, proper autonomy does require education or proper informed consent. Looking at the topic of medical malpractice, the legal system of medical malpractice was obviously designed to improve patient safety. There are some obvious drawbacks that have been identified. I think the main one is physicians working in the area of defensive medicine simply for fear of litigation, and it has some negative consequences. The one I listed here is thwarting honest discussion on how to improve or prevent errors or adverse outcomes, and also maybe prohibiting full treatment or adequate treatment in certain areas. There have been some reforms designed to deter frivolous lawsuits. Caps on economic damages has been implemented. Pre-trial screening panels, and the pre-trial screening panels are essentially, the way they sound, provide an opinion on whether a claim has sufficient merit to proceed to trial. The next one is certificate of merit, and that is it requires the plaintiff to present an affidavit certifying that a medical expert believes that there's a reasonable merit for their case. And the last one is an attorney fee limit, limiting the amount of money that an attorney can get or take in a contingent fee arrangement for a claim. And then finally, when it comes to medical error, medical malpractice, certainly there's been a lot more recognition over the last decade or so on disclosure and apology and the advantages to that. It may increase frank discussion about errors, provide fair compensation to the patient, and decrease costs for the physician and institution. It rejects the traditional deny and defend approach that has been taken for a long time, and this has been proven to be a better all-around approach to patient errors and near misses. This is just a list of some of the laws and regulations that affect physician practice. A lot of them you're already aware of. HIPAA, I'm not going to really talk about. The Affordable Care Act, also known as Obamacare, you are all well aware of, I'm sure. Mandates that individuals carry health insurance. It did launch health insurance exchanges and increase preventative services and restructured Medicare reimbursement. The third bullet point there is HITECH, the Health Information Technology for Economic and Clinical Health Act, simply instituting and developing a nationwide information technology infrastructure to improve healthcare quality and coordination. The next bullet point is the EMTALA, the Emergency in Medical Treatment and Active Labor Act. This just helps to prevent dumping of patients and not refusing treatment in certain situations. The next one is the Employment Retirement Income Security Act, or ERISA. It should be ERISA. This established uniform standards to protect private employee benefit plans. Then the last one that certainly affects us to a certain degree is Controlled Substance Act, which permits federal government to regulate, manufacture, import, possess, and distribute certain drugs to control traffic of controlled substances. These are simply kind of an FYI and just have awareness of these things that affect physician practice. Getting into informed consent, I'm going to quickly talk about the 4 areas that seem to be the most important when considering informed consent. The first one obviously is the patient's ability to make a decision, and this can be inhibited certainly by their mental status, whether it's chronic and baseline or whether it's them receiving sedation from us or on the floor. So these are things that need to be considered when getting informed consent from a patient. So the patient needs to understand medical problem, the proposed treatment, the foreseeable consequences of refusal, and the ability to express a preference. All these need to be present to assure that the patient has decision-making capacity. Second one is voluntariness, and this can be compromised through manipulation, which is deliberate distortion or omission of information, and coercion, the use of a credible threat to ensure complicity. So, I don't know, that's kind of as described, not much more I need to say about that. Disclosure, simply providing information relevant to the decision maker and the decision to be made. The courts and law look at what is considered the reasonable person standard, and this is the extent of which disclosure must be based on what a reasonable person would consider material for choosing whether to undergo a proposed intervention or not. And I think that's just kind of a general opinion. I'm not sure if there's a gold standard for the reasonable person standard, but just kind of common sense is what it seems to me. There are exceptions, however, to this. The first one would be a patient who chooses not to be informed. I know I've encountered this, and I'm sure you have too, where you go to see a patient and start describing the anesthesia, risks and benefits, and they say, I don't want to hear anything, I don't care, I just want to go to sleep and want to wake up at the end. And if they say that, then that's their prerogative. They don't necessarily need to know the risks and benefits if they choose not to hear those. That is their choice. And then the second would be emergency situations, and certainly we've all encountered those. There's another term called therapeutic privilege, which is a rare situation in which the provider thinks that if they withhold information, it may cause the patient to become ill or emotionally distraught and would hinder treatment of the patient's health. This would be an extreme example, and I can't even really think of anything where you would not fully disclose something, because if you did, they would become so emotionally distraught that it would prohibit proper treatment. So I can't think of a great example. Maybe we can talk about that during the lecture. And the last one, when it comes to informed consent, is recommendation. Physicians and anesthesiologists should offer an opinion about which options are preferable and the advantages and disadvantages of each. And the easiest example that I can think of, and I do this frequently, is when I talk to a patient about having a surgery under general or spinal anesthesia. And I am one, as you all probably know, that certainly favors spinal anesthesia, so I will tell them at the end, it's up to you, you can decide, but if it were me, I would prefer spinal anesthesia. And here are the reasons why I think it's better and beneficial. And these are certainly things that, if you have a situation where you have one option versus another and a choice, it's perfectly appropriate and probably necessary to offer your opinion or recommendation. Moving on to the next topic, which is end-of-life care. The first really important point to keep in mind, and this also keep in the back of your mind when we talk about some of the ethical scenarios in class, is that competent patients have virtually unlimited right to refuse potentially life-sustaining medical treatment. There's a term that they refer to called substituted judgment, and this is when a patient's preferences are not known. You can use surrogates and their intimate knowledge of a patient's attitudes and beliefs to determine what the patient would have chosen. Obviously, if the patient is competent and with it and communicate, then they have the right to refuse anything. If you're in a situation where you don't know what to do, you can use this substituted judgment clause that can help guide treatment decisions. Advanced directives, there are the three types that I've listed here. The first type of advanced directive is a living will, which allows patients to declare the extent of desirable interventions. The second one is healthcare proxy, also known as durable power of attorney. This is where a surrogate decision maker can make decisions for them should they be unable to. And then the last one is physician orders for life-sustaining treatment, or POLST, and this supplements advanced directives by focusing on advanced planning for seriously ill patients or situations. Of course, in anesthesia, there are unique situations that we encounter. Pediatrics, obviously, in kids, their ability to make decisions and decision-making capacity can vary. Obviously, when you've got a 2-year-old, they're not going to make competent medical decisions, but there are many teenagers or most teenagers that probably can make decisions regarding their own health care. For those that have never been autonomous, the care relies on respect for human dignity, beneficence, avoidance of harm, and adherence to justice, so little kids. But certainly when you've got a child that is old enough and competent enough to understand what type of treatment or therapeutic intervention they might be undergoing, they have the right to participate in that conversation and make decisions, even if legally they are not signing their own consent and they need a parent or guardian to do that. The pregnant patients or parturients, so the rights of pregnant women to refuse therapy, even if it will be detrimental to the fetuses are protected. And it's really significant the conditions that are necessary to override a mother's refusal. And these are the three things I've got listed here that would have to override a mother's refusal for treatment. The fetus, it has to be proof that the fetus will suffer irrevocable harm without treatment, that the treatment is clearly indicated and likely to be effective, and that the risk to the woman is extremely low. Those three things all have to be present in order for someone to legally override a mother's refusal of treatment. So it has to be, again, significant. And the final topic, DNR. This is kind of a misnomer sometimes for patients coming to the operating room that have a DNR order. I remember thinking this as a resident as well, that if a patient came to the OR that had a DNR order, that it was automatically suspended. It's not necessarily the case. It's the duty of the physician, anesthesiologist, to discuss the risks and benefits of resuscitation in the setting of anesthesia and surgery with the patient or the patient's family, and the caveats of that. So it should never, a DNR order should never be construed as an excuse to not care for the patient. There should be frank discussion on what the procedure the patient is undergoing is, different scenarios, what type of interventions might take place, whether it's intubation and prolonged intubation, resuscitation, chest compressions, things of that nature should be discussed if necessary for a patient that comes to the operating room with a DNR order. Lethal injection versus withdrawal of care or letting die. There are kind of two distinct situations here, and it's defined by this term, the principle of proportionality. In the case of withholding or withdrawing care, the question of whether treatment is indicated to the extent that will present more benefit than burdens to the patient is based on the patient's perception of such medical, social, and psychological benefits and burdens. So what that first bullet point really is saying is just you have to take in all of the situation, the patient's condition, every social and medical, psychological aspects surrounding the patient, their wishes, their beliefs, and this is in the situation of withholding or withdrawing care, which is in stark contrast to lethal injection, which is intentional killing, and it's been long stated by U.S. professional organizations that it is unethical for a physician to be involved in executions or lethal injections. Finally, Jehovah's Witnesses. This is obviously something that comes up a lot and is a common ethical situation that we may encounter, and some of you may have already encountered it. So the courts do strongly support the rights of adult patients to refuse blood products. There are some unique situations that need to come into consideration. Pregnant patients. The rulings on pregnant patients have been inconsistent, and again, I would go back to this middle bullet point here on the previous slide where parturients, where the right of a pregnant woman to refuse therapy, even if it will be detrimental to the fetus, are protected. And there has to be those three things involved for them to, for somebody to override their wishes. So in the case of a Jehovah's Witness, I think the same things apply, and you have to have a pretty great evidence to overrule a patient's wish to not refuse blood products. And the last one is pediatric, and I think it's a little more common for courts to override and to rule in favor of transfusion for the child, and certainly especially in a life-saving situation. Really, I think the key with Jehovah's Witness is communication, learning the wishes of the patients and what the situation is, and certainly if you have enough time, having discussions with the religious leaders in the community and getting the courts involved if necessary as early as possible, and certainly trying to do what's best for the patient in regard to beneficence and non-maleficence. The last one is physician-assisted suicide, also very controversial. Currently, this is legal in the states of Oregon, Washington, Montana, and Vermont. Internationally, it is legal in the Netherlands, Belgium, and Luxembourg. It certainly does require the patient to be competent and capable of communicating that request. And that's it. So here are my references. So for lecture tomorrow, what's going to happen, or for lecture coming up, I want you to keep some of these terms in mind, some of these situations in mind, and we're going to go through some clinical scenarios in small group settings to try to discuss things and talk about the ethical implications, and again, keep these terms that I've got listed here in mind and understand the definition, and then going back to our objectives. Take a look at these and make sure that you understand each of these objectives. You should know each of these now that I've talked about, and hopefully this will get you a few extra points on your basic exam and help with knowledge going forward in practice. Thanks. Bye.